Hello, everyone. Thank you for joining us for Life After Prostate Cancer. My name is Bree Kimberly. I am a nurse here in Community Health and Wellness at MKC Health. Just wanted to let you know we do have the chat open and the Q&A open, so please put your questions in there, and I'm going to prompt those to Sue at the very end of her presentation so we don't interrupt her. But please know that we do see them. If you registered for this presentation, you will get an email from me in the next week or so detailing more of the links, maybe if Sue mentioned something or her PowerPoint. Also, a link to our YouTube channel, which has a lot more content, not just about physical therapy, but about nutrition, diabetes, etc. So please go check that out. I'm going to turn it over to our speaker, Sue Condon.
Hi, everybody. My name is Sue Condon. I am a physical therapist. I am also the director of Rehab Services here at NKC Health. I do have over 20 years of experience with pelvic health floor issues for both men and women. And I think this is a topic that's very timely to share with you. And hopefully, you'll come away with some strategies that will help you and understand what services we have to help you as well. So today, my objectives are to teach you about the male urinary system, what's normal, what's not, talk about post-prostatectomy and why leakage is fairly common, understanding how you can manage those leakage strategies. We'll talk briefly about some issues related to sexual issues and erectile dysfunction. We'll also consider the side effects from some of the other cancer treatments that might be suggested or recommended for your care. And the biggest thing is don't be embarrassed. This is an area we often don't talk about, especially at the dinner table, but there is definitely opportunity to share with some pearls of wisdom for you. So without further ado, let's start in with the male urinary system. I'm going to use my mouse over here as long as everything's behaving properly. So where my arrow is right now, I'm kind of circling what is the bladder. So we get urine that drains into the bladder from the kidneys, comes to the bladder through two small little tubes that are called ureters. That's where kidney stones happen. So if you've ever had that, I feel for you. But then when we want to empty the bladder, there's a long tube here. I'm going to trace it with my mouse. This is called the urethra. The urethra passes urine. It also passes semen. And in the male, it's about the length of a drinking straw. In the female, it's probably about the length of my thumb. So it's pretty short in the female. So we treat a lot of female incontinence leakage issues. But we treat some with men as well, and it's very common after prostatectomy. So the prostate is this round gland up at the neck of the bladder. We think of it kind of like a walnut shape, and it's about that size. So one of the things that the prostate does is it adds fluid to semen. It helps to push that semen through this urethral tube. And then I always like to share that it's kind of like the rubber band at the neck of the bladder, so that it kind of helps to control you from leaking or having incontinence. But as the prostate gland enlarges, which is pretty common as men age, it can actually constrict or cut off this urethral passageway. So a common thing that men will start to report is that, or I will notice, I've noticed this with even friends, is that they're going to the bathroom a lot, and they'll go a little and then they're done. And then they go back and have to go a little and then they're done. So that tube, that urethral tube, is probably getting some restrictions to it because of the enlargement. And that's probably a good indication to go have your prostate checked. It doesn't always mean it's cancer. It just could be an enlargement that could be managed with medication. It could be some type of a swelling, which can happen if you've maybe been hit or struck in that area. But it definitely could be prostate cancer, and it is one of the second most common types of cancer for men. So if it is prostate cancer, it's a very treatable condition with very good outcomes, but that's what we're looking at with that. So, and then we'll move on. This is another view. This shows those ureters coming into the bladder. This is a frontal view. Here again is that bladder, and then the urethra where the urine comes out. And again, here is that prostate gland. And I like to have you see the difference between the man and the woman here. Women don't have the prostate glands, so they've got this tube, just like the men have the urethra, but they don't have a lot of distance. Remember, they've also got a sphincter, just as men have a sphincter, to help with urine control. But definitely men have an advantage with the help of the prostate. Here is, so we talk about the pelvic muscles and where are those pelvic muscles? This is an external view. So if you were looking up underneath a man, and or if they were laying on a table with their legs spread, this is the view of the pelvic muscle. Obviously, we've got some skin pull it away so that you can see the muscles. So we've got the tailbone back here. We've got the rectal opening here. Here we've got the penis. So this layer of muscles, which has about 3 layers thick, and it's about 26 different muscles are in there, is what we call the pelvic floor. And we often think of it like a hammock or like the base of your body, so to speak. And so the hammock, think about a hammock between 2 trees. When the hammock starts to sag, we might go up and pull the strings up on the tree and bring that hammock up. So in the human body, if our pelvic floor starts to get weak or sag, we need to work on getting it to contract and do its job. Naturally, it has some reactivity that makes it do its job, but if it's impacted by a stroke, you'll lose muscle control. If it's weak, you can lose muscle control. And with the prostate, you've lost one of your helpers with that neck of the bladder prostate gland. So we need to bring those those pelvic floor muscles up to function a little better. So one of the best things we can do for pelvic function in both men and women is walking, and any kind of exercises involving the legs help to strengthen the pelvic floor. The pelvic floor muscles have 3 main functions. They're supportive. So above them is the rectum and the bladder, and those are held up in the cavity by some ligaments, but you also just have to have something underneath to hold them up. Sphincter, meaning they're sphincteric, there's these openings. Again, we've got the rectal opening here. We've got that urethral opening that we've showed earlier. So it helps to close off those openings. And then it has a sexual function. So sexual activity is actually really good for pelvic floor health. I say this to women and men. That helps to work on that contractility component and keeps that muscle strong. So as we age, we may not have sexual activity as often. We may not have a desire. We may not have a partner. We may have hormonal changes that impact that. So we start to lose some of the activity already, which is aging. But we also aren't as active maybe as we were younger, and we're just not using that pelvic floor as much. Here's another diagram. So this shows the pelvis, and if I look down into it, I've taken out the bladder, the rectum, and all the parts, just to again illustrate that basement of the body and how important that is. We don't think about it until we have a problem with it. And then we think about it all the time. All right. So I'm not a surgeon, I'm a physical therapist, but I think it's important for you to understand some of the approaches that are used with removal of the prostate. This is something you would discuss with your doctor, and the doctor will tell you what procedure they're planning to do or hoping to do. Sometimes when they start laparoscopically, they may find that they're not being successful and they need to do something more open or radical, but usually the doctor pretty much knows as they walk into the surgery their plan. So they may go in laparoscopically to kind of do a vacuum suck of the prostate or just to chop it up and then pull it out. They may have to do something more radical where they go either abdominally and cut into the body to get to the prostate, or they may go more in that perineal region between, again, the rectum and the penis to get to that prostate gland. That would be a little more invasive and definitely would probably be an indication if they felt like there was more than just the prostate gland involved, such as lymph nodes and that. And then there are robotic assisted, and surgical advances are coming around all the time. So it gets better and better as we get older, for sure. This is going to show you then what things are going to look like after the prostate is taken out. So over here on the left-hand screen, I've got my arrow here. I've got the prostate gland. There's the urethra. This is the vesicle that goes to the seminal vesicles where the semen is made and comes in. So here it is enlarged before surgery, and then here it is after. And I want you to appreciate there's about an inch here that's probably taken away. They're removing the prostate gland. They may also be removing an internal sphincter in there as well, depending on how extensive. Here's another illustration of that. So we've got the tumor. They take and maybe remove the entire prostate gland. There's again about an inch there, and you're going to see that there's a definite shortening there. Okay, so just be prepared for that. Here's another illustration. I like this one because it demonstrates that once they get that prostate gland out, then they're going to reconnect the urethra to the bladder so that you have a way to go to the bathroom. Hopefully they're going to spare this neurovascular bundle in their procedure, but there could be some damage or there could be some temporary damage to that bundle as they work to do that. But there again is another illustration of what that surgery is going to entail for this taking out the prostate. So things that we want to make sure you understand. There is going to be a shortening of the penis. We've heard people come back to their doctor and go, what happened? My God, my penis is shorter. Yes, it is. And again, it's about an inch that they maybe have taken off. So expect that. Don't panic about that. That's expected. It's expected that you're probably temporarily going to have incontinence, which means that you're not able to control your urine and holding of your urine. You may have some impact on sexual function, and I would say that if you were having an impact before the surgery, there may be other issues, and we'll talk about that later. But again, we've had that neurovascular bundle involved, the prostate gland getting semen. There's several things that could be impacted. And then finally, there could be other impacts depending on how extensive the surgery is with lymph node removal. And if there's other tissues outside of the prostate, perhaps where the cancer cells are that they've had to remove. So we want to just keep in mind those are impacts. So let's talk about incontinence. Incontinence is very manageable. After surgery, it is normal to have a loss of control of urine. It can happen for several weeks or months. And I want to help you as a physical therapist and a pelvic health therapist to know that this is not something that you should just accept. Your doctor will definitely tell you, and it is true, it will get better. But I think a pelvic health therapist can help you get it better a little quicker. It does recover in stages, and it's very uncommon to have what they consider a continuous incontinence. You would probably have some, periodic leakage in that. So we think about 3 different types of incontinence when we think of incontinence. The first one is stress incontinence. So with stress incontinence, think of that as that push down like a cough or a laugh or a sneeze. So the diaphragm pushes down and that pushes down against the bladder, and the pelvic floor has to come up and contract to keep you from losing urine. And sometimes that pelvic floor has gotten a little lazy. It's not doing that job like it should be. Remember, you had help before the prostate surgery, so maybe that wasn't quite the issue. But now that you've lost that rubber band around the neck of the bladder, you don't have the helper. So you're really much more dependent on that pelvic floor to be stronger. And there can be some damage to the nerves in that feed the pelvic floor. And again, it could be temporary. It doesn't mean long-term, but it's not uncommon to have that kind of incontinence. The other type of incontinence that we often hear about is urge incontinence. And I think of this as the key in the door. I just went to the bathroom before I left work, and then I get home and I'm like, oh my God, I've got to get to the bathroom now. It's this sudden feeling of I can't hold it. And so a lot of times this has a lot to do with how the bladder stretches and fills and its filling capacity. The bladder normally should hold about 2 cups of fluid. Your bladder might not hold 2 cups of fluid before the surgery. So even after the surgery, it's going to be more of a challenge. So we've got to retrain that bladder how to hold. You may have heard the term, I've got a pea-sized bladder, and that could be really accurate. If you're going to the bathroom all the time and never challenging your bladder to get full, then for sure you are going to have a shrunken bladder and it's not going to have that capacity. So we want to build that capacity. And then you could have an overflow incontinence. And again, back to when the prostate was there, it might have been constricting that urethra. After the prostate's removed, there still could be some scar tissue that's affecting that urethra. And this next slide kind of shows all three of those. This is where that scar tissue, even though the prostate's gone, we still may have some scar tissue that's making it hard to go. There's almost like a kink in the hose. The stress, that's that downward push, and we have to have an equal and opposite upward contraction. And then finally, the urgency issues. And it's not uncommon to have a combination of all of these, or 2 or 3 of these. So just know that we kind of ask a lot of questions to kind of discern, is this more stress incontinence, more urge incontinence? A lot of questions go into this. So be prepared for some of those answers. So how do we manage it? There's 3 main ways, and this also applies to women, but we're going to talk just men. So surgery could be number 1, but I wouldn't say it's number 1 as far as the first means, because you've just gotten through with the surgery. You don't want to have another surgery right away, and your doctor probably wouldn't allow that anyway. So surgery is going to be way down the road if that needs to happen. Medications are certainly effective. There's a lot of incontinence medications that interact with the sympathetic nervous system to control urge. They probably work better on urge than they do on stress incontinence. But again, there can be side effects. They can cause a dry mouth, dry eyes, things like that. Sometimes they start to lose their impact as well. When I see people and they have started on a medication, I don't mind that at all. I'll just say, okay, well, you're on the medication. Let's work on that muscle. And then our goal would be to gradually get you off the medication. So sometimes it's nice to have that in conjunction with pelvic health therapy. Pelvic floor therapy works on retraining the muscles. And there's some lifestyle techniques that we also teach you, but we're really focused on that muscle. And the best thing that could happen is that your doctor refers you to pelvic health therapists before the surgery. We can kind of walk through what to expect post-surgery, and we can get you on the track of doing exercises before you go into surgery so you understand how to develop some continence. And then I think after the surgery, we can do a follow-up visit and just make sure that we've got you on a good exercise program. And sometimes if you get it before surgery, you might not need us after, but I don't think that we're going to harm you by being involved both before and after. And if your doctor never referred you and you're having issues, maybe you had your prostate surgery several years ago, we can still help you with incontinence issues. We can still make a difference. So we have at NKC Health several therapists trained with pelvic health experience. We've gone through specialized training to learn how to teach you to retrain these muscles. We have advanced skills on what to look for. We can do internal assessments, but we don't have to. So don't be, worried like, oh, I don't want you down there. As long as maybe I can look at that area so I can see what the muscle is doing, then I can coach you on what to do. But I've even treated patients where we never went that far. We just really talked through situations and I gave them strategies. So we can do it a lot of different ways, but we'll ask a lot of questions. So be prepared for that. One of the things that I like to start with as a pelvic floor therapist is teaching you some breathing techniques. And you may go, what do I need to learn to breathe? Well, if your breathing is kind of a chest and shoulder breather, you're not getting that good belly excursion and that diaphragm movement. So a lot of times, and breathing also will help to kind of quiet the nervous system. And the other thing about breathing is we're going to teach you to work on a muscle that you can't necessarily see. It's not like my arm where I can see myself moving it up and down. this muscle is kind of down below, down under, so to speak, and you may not see it. You can hold a mirror down there and try to look at it, but it's pretty hard. So it's kind of nice to get your body quieted down, because then you're going to just focus in on that pelvic floor once you have kind of quieted things down. So one thing I like to do, and I'll stand up for this, I like to have you put one hand kind of underneath the diaphragm or rib area, one hand on your lower belly, and I just like you to breathe in and out. And you want to feel that diaphragm. When you take a breath in, it's going to go down, but the belly's going to go out. And then when you let that breath out, the diaphragm's going to rise up and the belly's going to rise up. So just kind of doing that for 10 to 20 seconds kind of gets you quieting the system and kind of gets you aware of your breathing. And breathing is very helpful for pelvic floor therapy. Okay, so nobody's probably ever taught you how to find your pelvic muscles. So today we're going to teach you a little bit about that. So this picture here, again, I want to just illustrate this where my pointer is the pelvic muscle. So tailbone, pubic bone, okay? And this hammock of muscles, that's the muscle that we're focused on. This muscle up here is more of your abdominal region, and we're not going to touch that for a minute. We're going to just focus on these pelvic muscles. So there's a couple ways you can find your pelvic muscles. The first way would be that you put your fingers externally on the outside of like your pants, and push until you can find this kind of hard ridge. And that's where what I'm pushing on is my pubic bone. Okay. Now, if I closed my eyes and I visualize that I'm bringing that pelvic floor up to my pubic bone, that's the pelvic muscle. Another way to do it would be to, in your chair where you're sitting, think about lifting those muscles up off the chair and then putting them back down. And if you can't quite feel that, you might fold up like a washcloth or a towel and sit on that. That'll give you a little more pressure on that perineal region in here. And then try to pull that muscle up off that towel or washcloth. That's another way to contract those muscles. Another way, men have the advantage, they do have one external thing, which is the penis. If they stand in front of a mirror and they contract the pelvic muscle, the penis will kind of rise. It's not going to be like erect. I'm just saying it's going to kind of pull up a little bit. And I tell people it's kind of like if you're an ice fisherman, it's like the tip up of the flag. It's not erect, but it's just that is contracting that pelvic muscle and influencing that penis. So lots of different ways to find the pelvic muscle, and these might be things you practice on yourself. Now, here's the key. Nobody should know you're doing it. So I could be sitting here and doing pelvic contractions. Nobody should know. If I'm bouncing up and down, I'm overdoing it. If I'm holding my breath, I'm not doing it. If I'm using everything to, kind of contract up, I'm not doing it correctly. It's a very small area of muscle that feels kind of like a wink almost. And so it's important. That's where a pelvic health therapist can say, yep, you've got it, or nope, you don't have it. And then we can assess things like strength. We can internally, through the rectal region, we can determine how strong of a contraction you have. But externally, we can do a couple of things. One thing is I would have you contract, and you could do this yourself. You can push on that pubic bone area or just close your eyes and contract that muscle up and count to 10 and see how long over 10 seconds do you feel like you've got that muscle held up. You may find that about 5 seconds in, you're like, oh, I don't think I'm doing, and you're trying. So if that happens, 5 seconds is probably your strong point. And so we're going to work to get you to 10 seconds, but right now your baseline is 5 seconds. The other thing we can do is we can count, if you just, instead of holding, can you contract, relax, and how many of those can you do out of 10 reps? If you start to kind of fizzle out after 5 or 6 of those, that's kind of where your baseline is. So those are really simple ways for us to get an idea of pelvic strength. And then we create a program for you to work on at home. So a lot of pelvic health therapy is assessing your baseline, figuring out where you're at, and then giving you strategies to work on at home. It usually does not involve coming in multiple times of the week to see a pelvic health therapist. My general rule of thumb is I like to have you doing 30 repetitions a day and not 30 all at once. In fact, I would use that fatigue factor of how many repetitions out of 10 you can do. Let's say you can do 5 really good ones, then 5 holding for maybe if your baseline is 5 seconds, I might push you to 5 to 7 seconds of a hold. And I'm going to have you doing that 5 repetitions at a time. And to get my 30, I'm going to have you do it 6 times of the day. And you may go, oh my God, how can I do all this? Well, you're sitting at a stoplight. Maybe you're standing in line at the grocery store. Maybe a commercial comes on TV. You're working it in throughout the day to get that exercise done. So it's not something that you have to set aside a lot of time. In fact, we almost recommend you spread it out over the time. Again, you could be doing them at work and nobody should know you're doing them. If people know you're doing them, then you're probably not doing them correctly. We also will then try to work to coordinate the whole breathing component with the pelvic component. And I won't spend a lot of time on that, but what I want you to think about, like if you try these things, like let's just pretend that you cough. I want you to cough and think, did my pelvic floor come up, which is what we want it to do, or did it just kind of stay flat and do nothing, or did it push out? If it's not coming up on command, it might be again like a timing chain with your car. It's just not reacting quick enough. So one of the things we'll do is teach you some strategies to kind of incorporate it with normal activity. My favorite to do is have you work every time you go to stand up from sitting down, maybe contract that pelvic floor and then stand up. That movement, that change of position, the diaphragm naturally pushes down with standing up, and that pelvic floor learns to come up. You could also, I know I'm going to cough, I'm going to contract, and I'm going to cough. But those are all things that a pelvic floor therapist can help you work on. The biggest thing we don't want you doing is holding your breath, because that actually puts more pressure on the pelvic floor. And that makes it harder for you to stop leakage. We would bring in your core muscles into this, but again, I like to break it up into breathing, pelvic exercise, and then core muscles. Core muscles kind of come at the end because too many times we're trying to do everything at once and we're kind of not isolating the muscles really well. And core muscles are really important. These diagram here shows that when the normal posture, the center person, that's when they've got a good strong core. But the core is definitely impacted. It's over lengthened here because it's just not holding this person up. The back muscles are short, the front muscles are too long. Here, the front muscles are way too long and the back muscles are short, so we've got to bring all of that in. And I like this caveman analogy as well, just to show you how important, and sometimes we do it to ourselves with our work in that. All right, other things we want to think about with continence, diet and fluid management. What's the first thing you think of when you think, well, I just won't drink as much because if I drink too much, I leak or I have urge. And that's actually opposite of what we want you to do. We really want you to get about 6 to 8 ounce glasses of water. Water's the best, very much the best per day. So we don't want you to cut your fluid intake down, because let's go back to that pea bladder. If the pea-sized bladder, if the bladder capacity shrinks, it's not going to hold well. So we've got to still challenge the bladder, and the bladder ought to be able to hold 2 cups of fluid. Normal continence is that you're going to the bathroom every 3 to 5 hours. If you're going every hour, you're going too much. If you're going 8 hours and your urine is still very dark, by noon, I always say if your urine is still pretty dark by noon, if that's your normal, you get up, say 6 or 7 in the morning. If by noon your urine isn't clear, you've definitely not had enough fluids. Now, do you have to stop drinking coffee? Not necessarily. We might coffee or carbonated beverages like soda, even decaf, are irritants to the bladder. So if you drink, say, 4 cups of coffee every morning, I might say, can we cut that in half? And what I might say is drink a cup of coffee and then drink a glass of water. And that way you're diluting some of that acidity from the coffee that's irritating. You're probably also filling yourself up a little bit where you may not need as much coffee. There are other foods like citrus foods, spicy foods. Those are all can be irritants. And we're not saying you have to cut them out. We're just saying in moderation or find some substitutes if you're like, I'm really struggling with this, because those are irritants to the bladder. And I can tell you time and time again, when I get a person that's a, heavy soda or heavy coffee drinker and they take our advice and cut back, they're like, yeah, that really made a difference. And it does. It really does make a difference. The other thing we look at with fluid intake is what's happening at night. So if you're getting up 2 to 3 times a night, then that's a problem too. Your body's not getting a good rest. You're not getting good repair of your muscles. And we want to look at when do you stop drinking fluid? Usually, if you're getting up at night, I would ask, when do you take your last, major drink of fluid? If you say, well, I drink right up to bedtime, I might say, why don't you think about if you eat, let's just say you have supper between 6 and 7 or 5 and 6. Let that be the last time you have a good glass of milk, water, whatever. And then if you need to take some pills or something before bed, just do it with some sips. But really try to cut back in that last 3 to 4 hours before you go to bed, and then get that bladder empty. And then the other thing about this is sometimes we've trained our body to get up. If my dog always gets me up at 2 in the morning, and because the dog has to go to the bathroom, he's training my bladder to get up at 2 in the morning to go too. And when the dog's not an issue anymore, and I'm still getting up at 2 in the morning to go to the bathroom, then I have to kind of untrain myself from that too. So things like watching fluid intake and also just kind of talking yourself out of it a little bit. There's a true nervous system component to bladder control that could be a whole nother lecture. But your body is designed, you're going to get an urge to go to the bathroom and you're going to either say yes or no. If I had to go to the bathroom right now, I would be saying no because I'm in the middle of this presentation. But after the presentation's done, I'm going to say, yes, it's fine to go to the bathroom. So you've got some control factors over that, and we'll talk further. The other thing is for people that tell me that they go to the bathroom, but 5 minutes later they go out and they think, oh, I didn't go, I got to go again. So the bladder kind of gets misshaped as we get older, just like the rest of our body changes in shape. So this nice vesicle may get a little pocket somewhere in it. So if I change positions, so men may stand to go to the bathroom, maybe they finish going, they shake, or they maybe sit down and then they stand back up and they see if they can go some more. It's almost a form of double voiding. Then that's an option that we would encourage them to try. And sometimes just that double voiding, and we'll do it with females too, like wipe, stand up, and then sit back down and see if you can get that urine that's in this pocket into the main vesicle to go out through the urethra. The other thing is we talk about time voiding schedules. So if you walked in and said, yeah, I'm going every hour on the hour and I can't hold, and if you tell me not to go, I get the urge to go and you're going to tell me no, that ain't going to work. So I'm a very goal-oriented person. So if somebody tells me that I've got to cut back on something, give me a goal. Like, what do you mean by that? So I might look at a bladder schedule with you. I might look at a bladder diary that you've provided for me to say, how often are you going to the bathroom? And then there may be periods in there where you can hold for a couple hours, but then you're every hour. And we're comparing that to what your fluid intake is. There's kind of a science to that. But I might look at your schedule and go, okay, it looks like kind of common. Every hour you've got this thought you have to go to the bathroom during the day. So you get up at 7 in the morning, you're going to go to the bathroom. I'm going to look at this schedule and I might say, let's pick an arbitrary number like 7 a.m. you go and your next time to go to the bathroom is 8:30. Whether you have to go or not, you're going to go at 8:30. And then you're going to reset the clock another hour and a half. Now, if you get to the hour point and you're like, no way, I've got to go. I'm not here to have you, soil your pants. I would rather you go ahead and go, but then back on that clock. And once you get that bladder kind of trained, like it trusts you, you're going to let it go. But it's going to build some capacity. You're going to be drinking these fluids. Oh, and also you're going to be working on that pelvic muscle in the meantime. So there's a lot that we can do, and it's no different than what you do. Let's just say you're in the car and you see a sign that says 30 more minutes before your stop. You say to yourself, can I wait 30 minutes or do I need to go? And if you say to yourself, I can make it, you've set a goal. And that's exactly what time voiding schedules do, is we set goals. And we're not super rigid. I always say when you're at home, be very rigid about it. When you're out and about, you can have a little more laxity, but it kind of gets your bladder to trust you again, and you're getting in control of the bladder instead of the bladder controlling you. And then with overflow incontinence, if our double voiding doesn't work, there may be times when we have to resort to catheterization, but that would be, after we've tried other things. The other thing for men after they've had a prostate procedure we can think about is what's called a penile clamp. And these are some pictures of those clamps. Basically, again, think about that urethra that's about 12 centimeters long. Now it's maybe about 11 centimeters long, but we're going to clamp it off. We're going to work on pelvic muscle exercises. We're going to have a timed schedule. So maybe we're going to clamp. We're going to say, okay, in 2 hours, I'm going to go to the bathroom whether I have to or not. So we're teaching the bladder to hold, but we're using the clamp as kind of an external helper until we get that lazy pelvic floor doing its job again. And the other thing about these clamps is that it would be important that you change the position of the clamp so that you don't cause skin irritation. But they can be very effective for getting that bladder control back. Other more invasive things, they can do like a collagen injection here at that base of the bladder to kind of puff up the area around the urethra. There are some good success with that. But again, I don't think your doctor would go to that unless it's been a considerable amount of time that you're not getting continence back after you've tried the pelvic health therapy route. There is also some more invasive things from a surgical standpoint where they can put in like an artificial urinary sphincter, and you'll have a little reservoir that you can kind of puff it up to hold. And then when you're ready to go, you release that air and you can go to the bathroom. There's also options like mesh, and this is done for females as well. So that again can kind of help with the holding capacity. Again, I don't think you're going to see your doctor jump to a surgical technique until it's been probably at least a couple of years from your surgery. So depending on your physician's mindset with that. Other things to consider. Erectile dysfunction. The first thing I would comment to this is if there was issues pre-prostate removal, those issues still have to be managed. So a lot of times erectile dysfunction can be a result of other factors such as heart disease, high cholesterol, obesity, etc. So my comment to this is you need to have those under good control as well. It isn't just a matter of the fact that you've had this prostate surgery. If those factors were a factor before the surgery, they're still a factor post-surgery. Also, psychological factors, including mental health issues, as well as hormonal strains, stress on relationships. Those factors too have to be, kind of shored up or in good management before we're going to jump to, how do we treat the ED? There's a lot of medications out there. Viagra, some of those, I'm sure you've heard of those. I would generally always say you talk to your doctor about these. I'm not an expert on any of these medications, so speak to your doctor. And again, some of those medications have some side effects such as headaches, gut issues, dizziness, things like that. And if those other heart issues are still a factor, I don't want you to just jump into one of these medications without physician guidance. There are, the other thing with the prostatectomy, back to the fact that we've shortened the penis, some people may see that the penis has a little kink as it heals, because remember, we had to kind of sew, the doctor had to sew that urethra back to the bladder. So there may be, as the healing evolves, there may be a slight kink. So there can be the use of a penile pump to, it's not necessarily going to increase the length, but it may help to reduce that kink. But penile pumps can also be used in the case of erectile dysfunction. There's a clamp at the base. You pump up the penis to get an erection, do your sexual activity, and then you can remove the clamp. I'm not an expert on penile pumps, but I just wanted to share with you that option is existing. And then there are other surgical procedures that can be used. And again, these would be things you'd want to talk with your doctor about. And again, may not have anything to do with the prostatectomy, but could be further an issue post-prostatectomy. The other thing we want to consider is the fact that you may have the prostate removal and the doctor may feel they've gotten clean margins and they don't need to do any further oncology-based treatments. But if they don't have clean margins or they're concerned that there could be cancer cells still living in your body, they may want to put together a treatment plan for you that might include chemotherapy. It might include immunotherapy, radiation therapy. There are so many cancer treatments now that we're fortunate to have. All of these treatments, very good. And again, you might even have some of these treatments before prostate removal to help shrink the tumor, and that makes the surgery even more successful. So they call that neoadjuvant treatment when they do it before any type of surgical procedure. But if they do it post-prostatectomy, either side of it, all of these treatments, although they're very effective, will have some side effects. You often hear of things they can have, and the side effects might not happen initially. They may happen over time. Like if I'm getting a series of chemotherapy, say over the period of 6 months, my body keeps getting chemotherapy buildup and those side effects could come on later on. They may be giving me the same dose of chemotherapy, but those side effects come on later. Immunotherapy is another treatment that's also used, and radiation therapy, where we're trying to, target with beams. With all of these, again, here are some of the side effects that we know can happen. Cancer-related fatigue. This is a type of fatigue that's not relieved with just taking a nap. And some people get extreme fatigue where they can't even function or get out of bed or go to work. And that is something that can be treated by a physical therapist. Another thing is neuropathies. So little tingling, numbness in your fingers, toes, extremities. And that can cause, difficulty with balance. It can affect your inner ear vestibular system. In addition, we can have some irritation to the lining, like in our throat, and any mucus pack, and that can make it difficult to eat. If your throat hurts and it's hard to swallow, we can also have some cardiotoxicity. Again, we've fixed the cancer, but our other organs in the body, like our heart, have to respond to this. It can cause some changes in just your thinking and processing of things. Sometimes we call that chemo brain. There can be muscle and joint tightness, lymphedema if lymph nodes are involved, breathing issues. So these aren't to scare you. I would always recommend, if I had the choice, I would want the cancer managed, but I would want to know that there's help on the other side. And that's where our cancer rehab and wellness services, we have speech therapists, occupational therapists, physical therapists, nutritionists that can help you through these. So our goal while you're having treatment is to keep you functional. We don't want you just laying in a ball in your bedroom and not doing anything. That's not healthy for you no matter what. We can give you strategies to manage some of these symptoms so that you can eat, so that you can go about your work if you need to work, those types of things. So some people are afraid to report some of these symptoms because they're afraid, oh my gosh, they're going to stop the treatment if I report this. That's not true at all. They may hold back for a minute, But they'll get us involved on that standpoint. And then after the cancer treatments are done, we're here on the back end to help kind of get your body back to what it needs to do from a restoration standpoint. And again, as I said earlier, we also have the pelvic floor component. So if this incontinence issue is just like, oh my gosh, this has got to go away, I would really say get in with us sooner than later. We can probably help cut that time in half and get you better from an incontinence standpoint. So not to be afraid of that and not to be embarrassed about that because we're very comfortable with these. So finally, we want you to be intentional. Anytime I'm going to take a trip, I make a plan. This is a journey through a prostate or any type of cancer condition. So let's make a plan. Let's set some goals. Let's focus on eating right, moving right, good sleep. And if any of those are a barrier for you, tell us what those barriers are so we can help you through those. We can't change what we don't know. And if you just ignore it and say, oh, it's going to get better, it's going to get better, it will, but over time. So in conclusion, again, bladder issues after prostate surgery, I don't want you to accept them. I want you to say, you know what, I want to be proactive on this. I know it's going to get better on its own, but it maybe can get better just a little bit faster. As I've shown you in this presentation, we have help for both leakage and erectile dysfunction issues. We also can help you through any of the cancer-related side effects. So, look at us as your partners through this, not as anything more than that. We will base treatment frequency based on use. So if you're like, I just want to come maybe once or twice, we can do that. We can absolutely make that work for you. This isn't like treating a total knee or something like that. We're not seeing you multiple times a week. We're giving you kind of the keys of what you can do at home and then going from there. All right. Any questions?
Remember that chat and that Q&A is open? I just learned so much, Sue.
Thanks.
I think that was fantastic. I love all of your visuals that you offered, different perspectives and views. That really, for my brain, helps me understand that pelvic floor.
I think so too.
So I kind of gathered that, especially when we have a new diagnosis or going to have a surgery, therapy sooner than later, or even before we have that surgery, can be just such a huge game changer for our recovery, right?
I think it teaches you what to expect. And I think if you go in blind, you're going to come out like, oh my gosh, nobody ever told me.
Yeah.
So I think we hear even from our patients, those that come before surgery feel so much more confident after the surgery. Like, oh, that's what she said was going to happen. Yep, that's okay. Not to panic.
Yeah, not to have an anxiety attack about something maybe you weren't aware of.
And if there is something that happens that's not unusual, you've got another person to call besides the doctor who may be hard to get a hold of and say, is this normal? Should this be happening? And we can tell you yay or nay. Like we can either talk you off the ledge and go, oh no, it's fine. Or we can say, yeah, I think call your doctor. I think that'd be a good idea.
That's one thing I love about anytime I've had physical, speech, or occupational therapy is the approachability of the therapist, and you often spend a lot of time with them. You build a relationship and a trust with them. And it's just a different medical professional to chat with, but they're often just so easy to talk to. And they have the time, unlike the other busy times we may go in and out of the physician's office. We have our set time to hang out with this therapist and really sit down, and they answer all those questions. And I love that.
Right. And I think a therapist that doesn't know the answer also can get the answer.
Right.
So, for sure.
All right. Well, I know you mentioned chemo brain. I wanted to plug our YouTube channel because one of Sue's employees, Stephanie Ramirez, she is like our brain guru. She does a lot of presentations for community health. She has several presentations on our YouTube channel, one specifically about chemo brain. So if that's something that is affecting you or your family member or friend, go check it out. And I kind of mentioned this earlier too. We have a lot of other topics on that channel, not just therapy, but maybe nutrition, diabetes, mental health. So please know that, we've got you covered here at NKC Health. Anything else you want to add, Sue? How do I get a hold of you? What if I want to come see you guys for therapy?
Sure. So, easy to get a hold of us. You can go on the NKC Health website and look under rehabilitation, our outpatient department. Our phone number is 816-691-1795. But if you forget that, just go on the website. And then even in the presentation, I think if I go back to these handouts, that phone number is listed. We do have several locations, and we know what locations do what. So we'll get you to the right location. We'll get you to the right professional as long as we know what we're seeing you for. Another plug I'll say is that if you're concerned about this, you don't have to have a referral from your doctor. We like your doctor to be the referring person, but if you're like, my doctor just keeps saying it's going to get better. If you want to see us, you can see us. You can give us a call and we can get you in what's called a self-referral. And then we always bring the doctor into that by sending him or her our notes so that they're aware that you're involved with us. And they're generally pretty good about, oh, no problem. I'm glad they called you. So you don't even have to have a referral to get to us. You can self-refer or walk into one of our departments and say, hey, I want to see a pelvic health therapist. And again, our front desk staff know who those people are, which clinics they're located at. So just know that we can help you from that standpoint.
It really is a team approach, right?
Yeah, it is. And the doctor's busy trying to figure out everything else for you. So we can't order medicine. We can't order x-rays, labs, those kinds of things. So we need the doctor. We need to be part of that team if anything more is going on. And we'll be the first one to help navigate you back to the doctor if there's something that seems to be outside of our scope.
Right. Well, thank you all so very much for joining us today. And thank you, Sue. Great presentation. And we hope to see you back here
All right.
next time. Have a good one, guys.
Bye-bye.